Good afternoon, everyone, and welcome to the Norton Infectious Diseases weekly grand rounds. My name is Valencia Brown, and I am a nurse practitioner with the Norton Infectious Diseases Institute. Please drop your email address, your professional title, the organization that you represent in the chat. This will help us gauge our audience better for future grand rounds topics. If you have any questions during the presentation, go ahead and type it in the chat box. The Grand Rounds is recorded, as David just mentioned, and available on our YouTube channel. More links will be appearing in the chat as we continue with this grand presentation. And then, without wasting any more time, I would like to introduce Dr. Alan Jenkins. He will be discussing the mathematics of laboratory testing in the age of COVID-19. Dr. Jenkins.
Okay, thank you very much. Hey, everybody. Yeah, I'm going to talk about the math of lab testing. This seemed like a little basic topic to some of you, but I won't cover it because of all the stuff we've gone through with COVID lately. We lab people, we tend to be content sitting in our basements doing our stuff and largely being ignored. We don't get in the limelight very much. But when COVID happened, all of a sudden laboratory testing was all in the news and everybody was getting all this, the general public was learning so much more about lab testing. Unfortunately, the headlines were all kind of stuff like this. It was press, but it was kind of bad press for the most part. And so we were really kind of ready to get out of the limelight pretty quickly. But it was issues like this that caused laboratories all over the country to do what we did, which was bring in multiple different platforms to test for COVID. Right now in our system, we have seven different ways that you can do to test for the SARS-CoV-2 virus. These are our 7 platforms that we have right now. Laboratories are not supposed to do that. That's not a good idea. You pick the one test you want to do and you stick with that. Maybe you have 2 tests, but we currently have 7. And that means over the last couple of years, I've gotten a lot of questions like this. What's the sensitivity? Which one of those 7 tests is best? My patient was negative 2 days ago and now they're positive. What does that mean? There were a lot of questions that came up regarding the quality of these lab tests. So I want to go into kind of how we look at the quality of different lab tests. I'm going to use COVID as an example, but all of this really kind of applies to any lab test. The way I look at it, you got 4 different types of lab tests. There are quantitative tests that give you a measurement, like your cholesterol level or your glucose level or something like a titer, a 1 to 80, or something that we say 1 + 2 + 3 + 4 +. That's semi-quantitative. One's higher than the other, but you really don't know what the difference is between those two, how much of a difference there is. A qualitative test is just simply yes or no, it's positive or negative, the virus was detected or it was not detected. And then there's what I call poly-qualitative. You won't hear anybody else say that. In fact, it's probably bad grammar because it's mixing Greek and Latin. You're not supposed to do that apparently, but poly-qualitative just sounds cool, so that's what I call it. It's basically a test where there's lots and lots of different qualitative results, like basically any culture. A culture could have hundreds of different possible results, and we could talk about each one of them. The sensitivity of a urine culture to detect E. coli, for example. I'm not going to get into all of that. The only thing I'm going to talk about today is qualitative tests, because that's what we use for COVID. It's just going to be detected or not detected. Now, here is information on the perfect lab test. Of course, there isn't one. Tests themselves are going to have problems. Every single one of them is going to have some false negatives, some false positives, and some that just come out where you can't tell what it is. It's uninterpretable. And even if the test itself was perfect, there's no perfect humans. So you're always going to have some specimens that are poorly collected, that were not transported properly. Okay. You're going to have specimens that are misleading. Then you're going to have times when things are clerical errors. When we try to enter data in the computer, for example, it may go wrong. So there's not going to be any perfect test. But we can describe the quality of a lab test. And the two things that really come to mind, the key indicators of the quality of a qualitative test are going to be sensitivity and specificity. Now, I want to point out that when we just say sensitivity or specificity, in a more accurate way, what we're really saying is diagnostic sensitivity or diagnostic specificity, because we'll get to a different type of sensitivity and specificity coming up later. So the sensitivity of test, if you are truly positive, if we're talking about COVID, if you are truly infected with the SARS-CoV-2 virus, the sensitivity is the probability that you will test positive. So for example, I get 400 people that I know have COVID and test them all. 380 of them tested positive. My sensitivity is 95%, 380 divided by 400. So if I'm going to give you a test, if you have COVID and I'm going to test you, there's a 95% chance that you're going to test positive. That's the sensitivity. Specificity is if you are truly negative, you do not have COVID. This is the probability that you will test negative. So I go out, I get 1,000 people. They do not have COVID. I give them all my tests, and 990 of them test negative. So that's 99% specificity. Now notice here, over on the sensitivity side, you got 5% that will be false negative. On the specificity side, you have 1% that will be a false positive. They don't have COVID, but they test positive for COVID anyway. That's a 1% false positive rate. So those are the two things. And every lab test out there is going to have some sensitivity or specificity associated with it. So we kind of look at that, we say that's kind of simple. It's kind of simple, straightforward. It's understandable. And most people I think have a pretty good grasp on what that is. But I'm here, as always, to kind of complicate things for you. So let's look into this a little more deeply. So for sensitivity, if you are truly positive, how are we determining truly? What are we defining as somebody truly positive? So whenever we're going to do this, we have to have what we call a gold standard. Now, you may think of the gold standard as being the best thing, the best. That's the best test. We kind of define gold standard as being the infallible answer. We are going to say, this is the truth. Now, we might have to do something like we're going to watch you over the course over several weeks here to see if you actually develop disease. We're going to do a combination of other tests. We might, in some diseases, may be able to look at pathology or something to see what agrees with it. But we will come to some kind of conclusion there, some definition of this is how we're defining you being truly positive. Same thing on the specificity side. This is how we're going to define somebody being truly negative. So the gold standard, by definition, in this case, is whatever criteria we're using to say, this is the answer. You have to agree with this, okay? Of course, that's a problem because what happens when there isn't a gold standard or you don't have a decent gold standard to go with? Then we do something slightly different, but it is important in this case. What we're going to do is we're just going to compare it to an existing test. Now, it should be the best test we can possibly get, but it's still going to be another test. And of course, we just said there's no perfect test. So your gold standard in this case is not going to be infallible. So in those cases, we're not really getting sensitivity and specificity. We're getting what's called % positive agreement and % negative agreement. Just how much does your test compare? How well does it compare to an existing test? So here's an example here. I'm going to use an existing test here. So for example, with COVID, we may be using the CDC's assay, okay, as our existing test. Then I've got my new test over here. So I take 85 people who tested positive by my existing test, and I go about my new test, give them all my new test, and 82 of those 85 tested positive. So that's a percent positive agreement of 96.5%. That's kind of a stand-in for sensitivity. I'm kind of using my existing test as if it were a gold standard, even though we admit that it's not. 177 people tested negative by the existing test. 175 of those tested negative by my new test. My percent negative agreement is 98.9%. Okay. Notice here, the problem is that your new test will never be better than the existing test. The best you can hope for would be 100% agreement with it, but it's never going to be better. This is a stand-in. This is not truly sensitivity and specificity, but we're saying this is the best we can do under the conditions we currently have. So the is going to be these three right here. Are those really false negatives by my test? You know, the existing test was positive, my test was negative. Or those situations where my test is actually better than the existing test. And same thing over here. Are these false positives or are they true positives that the existing test couldn't do? So it's a stand-in. It's something we can do, but it's not the greatest. So let's use COVID as an example. Here are tests that are all designed to detect SARS-CoV-2 virus. I got, 6 different molecular assays here and 2 antigen assays. And here's the sensitivity and specificity, except none of these are actually sensitivity and specificity. These are all percent positive agreement and percent negative agreement. You will not find, I don't think you'll find anywhere on the market today, a test for SARS-CoV-2 virus that actually gives you a sensitivity and specificity. They all show this is how we compare to another test, another assay, okay? And they won't even tell you what the other assay is that they compare to most of the time. So I don't have sensitivity and specificity data, but I have a stand-in for that, percent positive and percent negative agreements, okay? Now, a couple things to show here. First of all, these guys that say 100%, okay, remember, there's no perfect test. They're not actually 100% sensitive and specific. It's just that with the number of tests that they did with the other assay, there was 100% agreement. So don't think that this means 100% sensitive. That's not really what it means. It's up pretty close. It's not 100%. You also can look at some other things here. For example, one of the points that we want to kind of make here is you got your molecular assays, and one of the things that, you know, in the press, in the news, we've all been, molecular assays are better than the antigen assays. But you look at this, you know, this quick view antigen test actually has a better percent positive agreement than this molecular test does. You know, why is that? How can that possibly be the case? You know, maybe we should dump this and start using this antigen test instead. There is a reason for that we'll get to in just a second here. So going back to this slide, the other issue down here is, what are you actually testing for? I said down here, I had 100 people that I absolutely knew had COVID. That's what I was doing. But what am I actually testing for? And that is different between different assays. So for example, are we testing for actual COVID disease? I would say, no, we're not. What we're really testing for is SARS-CoV-2 infection, the presence of the virus. But are we using it to interpret it and say, okay, if you're positive, then you have COVID? That's the way we all think about this, right? If you test positive for SARS-CoV-2, you have COVID. COVID's the disease. SARS-CoV-2 is the virus that causes it. So how you interpret these tests differs. My test may have a certain sensitivity to detect COVID disease, but it would have a different sensitivity to detect SARS-CoV-2. And it would have a different, if we could calculate it, if we knew how to do it, we could calculate a sensitivity to detect a patient's infectiousness. Are they contagious? So you have to think not only about sensitivity and specificity, but also to detect what. Let me give you an example here of 2 assays. This is all taken straight from the package insert. And what I want to point out is that the package insert is not just the package insert. You kind of think of it as being sort of, the instruction manual. You take it out, throw it away. That's not the case. A package insert is a legal document. It is FDA approved. In the same way, when the FDA approves the assay, they also approve the package insert. And so as a laboratory, we are required to follow the package insert. If we go off the package insert, then we have to do validations to show that what we change is still working. So here's one. This is the Alinity M PCR assay that we use here in our laboratory, one of the things we use in our laboratory. And this is the Binax Now, which is the most common, one of the most common antigen assays that are out there. So take a look at what's written. Every single one of these package inserts is going to have as its first paragraph the intended use. And remember, this is not just description. This is legal requirement. So in this case, they both say this is for qualitative detection. We can only say positive or negative, detected, not detected. We cannot give any quantification, tell you how infected you are. You either are or you aren't. They list the specimens that are allowed. So for the molecular assay here, mid-turbinate nasal, anterior nasal, nasopharyngeal, oropharyngeal, BAL. Okay, or these same ones down here. So lots of different specimens that you can do. The antigen only anterior nasal swabs. That's it. If you want to do a throat swab, you're going to have to use this PCR up here. Okay. Then, really important, who is allowed to be tested? So for this PCR assay, individuals suspected of COVID-19 by their healthcare provider, or any individual, including individuals without symptoms or other reasons to suspect COVID-19. So anybody, I don't care if you are not having any symptoms. I don't care if there's no reason you have not been exposed to somebody. We have no reason to test you whatsoever. We can still do the test. But for this test down here, individuals suspected of COVID-19 by their healthcare provider within the first 7 days of symptom onset. So from a legal perspective, you have to have a healthcare provider who says you have symptoms that are suggestive of COVID-19 and you haven't had those symptoms for more than 7 days. If you've had those symptoms for 10 days, we're really not allowed to do the antigen test. And then it tells you where it's allowed to be done. Moderate or high complexity laboratories based on the CLIA amendments, or this one can be done moderate complexity, high complexity, or waived laboratories, which is going to be your point of care. If you wanted to do this in a point of care facility, you could do the Binax Now antigen test, but you could not do the PCR assay. Not allowed. So a couple of issues here. You might come up with these questions. Can I use the assay to test saliva? No, neither one of them. It's not listed in the approved indications. So you can't. If you wanted to, you could, but you would have to do a full validation. And what that means is I'm going to have to show, first of all, that SARS-CoV-2 is actually found in saliva during a naturally occurring infection. And then I would have to show that the test will be able to detect the virus in saliva adequately with a low enough limit of detection, that kind of thing. So we haven't done this. That would be a lot of work to do that. Can I use the assay to test asymptomatic individuals? Well, no doubt there with the PCR assay, yes, it says right there in the intended use, yes, you can do it. But for the antigen assay, no. Again, if I really wanted to do it, I would have to do a validation, which would be a lot of work to show that the assay is sensitive enough to pick up the level of virus that is going to be shed by an asymptomatic person. So you're kind of stuck with what FDA is allowing you to do. Okay, now step back a little bit. Let's say you are having surgery in a few days and you had to have a COVID test done. You have no reason to suspect you have COVID. You're asymptomatic. You have not been exposed to anybody as far as you know. You're really careful. You don't go out in crowds, that kind of thing. But you get tested and it comes back positive. Now, What do you want to know? I could tell you, well, here's the sensitivity, here's the specificity, or here's the positive agreement, and here's the negative agreement, okay? But that really doesn't tell you what you want to know. What you want to know is the positive predictive value, which is of all the people who test positive, what percentage are actually infected? Notice this is the opposite of sensitivity. Sensitivity was of all the people who are actually infected, what percent of the people test positive? This is the flip side. Of all the people who test positive, what percentage are actually infected? Negative predictive value is the same kind of thing up for the negative side. People who test negative, what percentage are actually uninfected? So that's what you want to know. And you can find these published in papers. You'll see them in package inserts every now and then. I blow it off. I don't pay any attention to that because it's easy enough to calculate yourself based upon your likelihood of infection. Very dependent on sensitivity, specificity, but really the likelihood of infection prior to performing the test. So here's an example. I'm going to show you how you can make these calculations yourself because it's really kind of fun. Well, for a geek like me, I guess. I'm taking a test here that's got sensitivity and specificity both are 98%. But here's somebody over here. At the height of COVID, well, I shouldn't say the height, after it kind of died off a little bit, when we were still doing all that pre-admission testing, everybody who was going to have an elective surgery ended up having a COVID test a few days ahead of time. About 3% of those were positive for us at that time. So if we say, that's your situation, you're asymptomatic, you have not been exposed, but you have to get this test because you got surgery coming up, the likelihood of you being infected is only like 3%. Well, then what I do, I always start with 10,000 people because it's a nice round number and I won't have to round off anybody. 3%, so 300 of those people are going to be truly infected, which means 9,700 are not infected. Now my sensitivity is 98%. So 300 times 0.98, 294 are going to test positive. That means 6 test negative. My specificity is 98%. So 9,700 times 0.98, 9,506 would test negative. 194 would test positive. So you add them up and you see that 488 people in this fake population, just like you, 488 people tested positive, but only 294 of those were truly positive. That gives me a positive predictive value of 60.2%, which means if the initial likelihood was 3% and now you've tested positive, the likelihood that you're truly infected is now 60%. Okay, and you can see over here that if we started out with somebody, let's say, they've been exposed, maybe they got a tickle in the throat. We're going to say, I'm going to say you're 30% likely to be infected. Now, when we say 3,000 here instead of 300 and go through the math, it comes out to now we're 95.5% certain that you're positive, that you're truly infected after a positive test. So there's a big difference here. The initial likelihood of infection really affects how you're going to interpret the result. And this makes perfectly good sense to us all. It's just you can put the math to it and get up with an actual number. So it's really kind of fun to look at what the effective initial likelihood is on how you interpret the result. Now, this is what scared me during this whole time. At this low likelihood of infection, testing all these asymptomatic, unexposed people, okay, only about 40% of the positive tests were false positive tests. Okay, now it's going to differ a little bit. Different tests have different sensitivities, different specificities. You may have a different initial likelihood, but I'm saying that when we tested the asymptomatic people, people who had not been exposed, there was a significant number of those positive tests that were false positives. And I worried about that a lot because how many times did we cancel surgeries because of a false positive test? How many times did somebody want to go on vacation and ended up getting a false positive test and couldn't go on their vacation? So those are all situations where you're like, that's an issue. This basically boils down to good diagnostic stewardship. This is a rule that we can talk about to physicians. If the test result, either positive or negative, is not going to lead to a predictive value that's high enough to make you take some action, either start treating the patient or rule out the disease or take some other action, then don't do the test. If it's not going to matter one way or the other, whether it's positive or negative, then you really don't need to do the test. Okay. Now, before you all start freaking out about this, okay, hang on. Are we saying that the way we did testing during the COVID pandemic was bad diagnostic stewardship? And I would say, yes, it was. But the pandemic was not normal, right? We did a lot of testing that was not for diagnostic purposes, but it was for epidemiologic purposes. It was for infection control purposes. It was just to get a handle on this pandemic. So rules of diagnostic stewardship really didn't apply. But my point is that the rules of math do still apply. The positive or negative predictive values still apply. So we had a lot of false positives when we were doing this. Now let me get to, oh my gosh, it's 12:26. Okay, let me get to a different part. Quality. Analytical specificity is, does it cross-react with other organisms? Okay, we don't really put a number on that, but you have to just demonstrate that. Analytical sensitivity is different from diagnostic sensitivity. Analytical sensitivity is how much virus has to be there before we're going to be able to detect it. And we call that the limit of detection. So I'm going to take this chart that we had earlier. I'm going to throw in the limits of detection here for these same assays here. Now you can see right off the bat, some of them are in copies per mil, which I think for most of us is pretty easy to visualize how many viral particles have to be there before it's going to be able to pick it up. And a lot of them are also in this unit called TCID 50s. What's a TCID 50? The amount of virus that's needed to infect 50% of cells in tissue culture. All right, everybody got that? I hope you understand it, because I don't really understand it. It's kind of a meaningless measurement to me. And the other problem with it, there's lots of variables that go into doing that. Companies will do that, TCID 50, because it's actually easier to calculate that than it is to come up with the copies per mil. But it's not good for molecular purposes. It's good for tissue culture assays. It's good for infectivity assays, but it's not really very good. There's not really a ratio here. I mean, look at this one right here, the BioFire and the Roche Liat. If you go by TCID 50, they're almost exactly the same. But if you go by copies per mil, the Liat is more than 10 times more sensitive than the BioFire is. So TCID 50 is really, to me, kind of meaningless. So look at it this way, you know, the Panther and the Alinity appears to take 5 times more virus, but I don't know. I don't know that at all, because we're not giving this in copies per mil. Okay, I will point out down here, the antigen test. Kind of look at, even though that I just said that you really can't compare TCID 50 from one assay to another, I think this is a valid comparison. 7,570 TCID 50s to be positive on the quick view, as opposed to 0.005. That's a big difference. That's about a million-fold difference. So what this is kind of saying is that you would need thousands times more virus to be there before the antigen test is going to pick it up. Okay. And you can also look at this now. Okay, here, why is this? If this has such a high limit of detection, why is it more sensitive than the Panther? Why is that? And the reason is, now we know we're testing different populations. But this Panther, a molecular test, we can test people who are asymptomatic, who have not been exposed. Here, we're really only testing people who are actively in the throes of symptomatic COVID. So the sensitivity is based on completely different populations. So that's why these antigen tests may look pretty good on paper, but if you look at these TCID 50s, or this limit of detection, it's really quite a different story. Now, how do we define the limit of detection? Let's take an assay here that has a limit of detection of 100 copies per mil, and I'm going to graph how much virus is actually in the specimen to the sensitivity. Now, if the limit of detection is 100 copies per mil, it might seem like it would do this. You know, where on this side of 100 it's detected, on that side of 100 it's not detected. If I gave you a specimen that had 99 copies per mil, it's not going to be able to detect it. If I gave you a specimen that had 101 copies per mil, then it would. Now, you got to know that, of course, it's not that simple. It's not a definite cutoff. The limit of detection is defined as the lowest concentration that can be detected with 95% sensitivity. So what I know about this assay is at 100 copies per mil, the sensitivity is 95%. That's the only spot on this graph that I actually know anything about. Okay. Now we can guess that what's going to happen is going to be something like this. You know, I'm making that a dotted line because I really don't know exactly where this line goes, but sensitivity is going to fall off as the viral load goes down, and it's going to inch up. Not going to get quite to 100 up here, but it's going to inch up. So really what's happening is everything on this side of that line is not detected. Everything on this side of the line is detected. And you will see that at concentrations down below the limit of detection, you will have variable sensitivity. That can be pretty bad. I say this right here because we have seen specimens that have had viral loads down in this range, and they'll test positive. Okay. If I took that same specimen and ran it 10 times, I might get 5 positives and 5 negatives. So sometimes a doctor would call up and say, you know, I really don't think this patient has COVID. You called it positive, but I don't really think they have COVID. Can you try it again? And we'll test it again. It comes back negative. That doesn't mean the first one was wrong. That means this patient may really do have COVID. It's just somewhere down below the limit of detection. So if we compare that to an antigen test, let's say the antigen test is something like this. This is his limit of detection, up somewhere around 10,000 copies per mil. And so the graph's going to come like this. So we'd have these, both tests not detected at this viral load. The PCR detects it, but the antigen does not. And up here, they're both going to detect it. Okay. So the question then becomes, what are you using the test for? What viral load is consistent with active symptomatic disease? Let's say it's here. If you got viral load up here, you've got active symptomatic disease, but it kind of trails off a little bit, right? So in this case, to look for active symptomatic disease, the antigen test works pretty well. PCR works great, okay? But the PCR is going to pick up a lot of things, people down here who do not have active symptomatic disease. So you could look at this and say, the PCR is going to be more sensitive, but the antigen test is going to be more specific if what we're looking for is active symptomatic disease. Okay? What viral load is consistent with asymptomatic infection? If this is the range that's going to be asymptomatic infection, the antigen test is not really very good, but the PCR is still great. Okay? And then the other question that comes in, you know, a lot of times when we're doing this test, we're saying you can't travel, you can't have surgery because you may be able to transmit the infection to others. What is the viral load that is associated with others? Well, we don't know. Is it here? In which case the antigen test will work great for picking up contagiousness. Or is it here, where the PCR works fairly well, the antigen works fairly well? Or is the range here, where the PCR is really going to be the better choice? And the answer is we just don't know what that range is yet. So the antigen test and the PCR test both have their good places, but it all depends upon what we're using the test for. And I will point out, just at the end here, because I've gone over time here, this is a requirement. If your laboratory is CAP accredited, then they are required to include in the report some kind of comment that gives you this information, how the test is done. It's going to tell you, should tell you positive, negative, predictive agreements, or positive agreements, or sensitivity, if you have that, and limits of detection. That is a requirement. Your laboratory should be able to give you that information on any of the tests. So my big points in all this: sensitivity, specificity, the percent agreements are all based upon the indications for use. What's written in that package insert? Predictive values are heavily influenced by the likelihood of infection at the time of testing. You know, how likely are you to be infected before we actually do the test? Limit of detection is not an absolute value. The test will still detect virus below that level, but the sensitivity is going to be reduced. And that means that the test really won't be very reproducible with that reduced sensitivity. The suitability of a test depends on all of that, why you're testing, what you're trying to get out of it, and how much virus there is there at the site of the infection. So, sorry for going a little late. That's what I've got. If there are any questions, we'll be happy to chat.
If you have any questions, thank you, Dr. Junkins. If you have any questions, just drop them in the chat. I actually do have a couple, Dr. Junkins. For COVID test, does the sensitivity and specificity differ between different variants?
Yes, probably so. These assays that are on the market now for SARS-CoV-2 detection, where almost every single one of them, all of their statistics was based upon the isolate of the virus from Washington State, the first COVID that showed up in states. They're all kind of based. So when Delta came along and BA5 or whatever we have right now, redone the assays. So specificity very likely will want between them. Now, when you want to use genetic sequences as your target, genetic sequences that don't vary much. Now, hard to do, we got one at the time, you know, vary, but now, you know, we can kind of look at genetics of all these variants and say, one sequence stayed steady to target PCRs for that. So just like we've gotten vaccines, you know, we're looking at several different variants at once. We are looking at PCRs that do the same thing. Now, the good thing about it is that almost all of these PCR assays, you have to be positive. So if it does cause a lack of sensitivity in one target, it's probably not going to affect the other target. So, but yes, the statistics will differ.
I don't see any other questions in the chat. One last question for our friends in long-term care facilities who have labs that are contracted and they're not in their facilities. How can they become more involved in learning more about different tests and this type of thing?
You know, yeah, if you don't have easy access to the laboratory that's doing the test, you should at least, first of all, they should be able to have in the report a paragraph similar to the one that I showed you, giving you some information on it. You usually go online. The package insert of these things will give you all the performance characteristics. You know, you can get the package inserts and they'll say that intended use be that first paragraph, and then down at the bottom, they're going to have performance characteristics. You probably won't care about all the stuff in the middle, but the very top and the very bottom might be of interest to you. You can get those online as long as you know the exact assay that your laboratory is doing. Some of the companies are kind of grumpy about not putting package inserts on their websites, but they're all on the FDA's website. So if you know the actual assay that's being done, then you can get the information from there. But you know, feel free to call up your laboratory and say, what assay are you doing? And can you share the package insert? Can you share? Every one of them is going to have done some sort of verification study to show that they can get this type study to work in their laboratory. So they should be willing to share that with you.
Okay, and I see Dr. Matthew Song has a question.
Yeah, thank you. Hey, Alan. Great presentation. This is, I think, very important topics to really help understand clinical care. I guess I want to clarify. I just want to make sure I understand this. So when it looked like when you were calculating negative and positive predictive values of an instrument theoretically that had a high sensitivity and specificity, and so it looked like the disease prevalence as it went up, or rather as it went down, it really affected that positive predictive value, but it didn't seem to affect the negative predictive value that much. So is that consistent, I guess? Is that the way to view it?
Yeah, that's probably true, largely because in most situations, you have a much larger number of negative results. Does that make sense? So it's kind of like, it doesn't affect the negative predictive value, still tends to be fairly high up there.
Okay.
If you had a situation where you started off with, there's a 95% chance that you're infected, then you'd see the opposite kind of effect.
So the negative predictive value is primarily affected by the population being tested, or the sensitivity of the instrument. I guess what's going to make the negative predictive value go down the most?
I think the main thing there is going to be the likelihood of infection before before you have the test. So at the time of the test, what's the likelihood of infection? I mean, if that's really high, then you're in a situation where you say, usually we get a lot more negative tests than we have positive tests. Because if somebody thinks there's a 5% chance or 10% chance, they'll order the test because it's worth it. Mm-hmm. But if there's a situation where you're saying, okay, there's a 95% chance that this patient's infected, well, first of all, you shouldn't be ordering the test. Just go with it, But if you did, then you would see kind of like that that positive result is not going to drop. Make sure you got me all confused here now. You're not going to drop that positive predictive value as much. Does that make sense?
No, I think so. Yeah.
I'm going to have to work it out on paper before I can really.
I mean, every time I try to get it straight in my head, I kind of get sideways too. And then I guess I had just a second question. I just want to understand if I am using this language correctly. So the sensitivity and specificity, these are somewhat descriptive of the instrument itself. I guess an example I tend to think about when it comes to sensitivity and specificity is like toxin enzyme immunoassay for C. diff. And so we know it's a less sensitive test. But then when we think about the sensitivity, I also know that like it's viable. It's not it'll degrade at 2 hours in room temperature. And so, in real life, it's like people aren't probably getting that down to the lab fast enough, put it on ice or whatever. And so is that like taken into consideration? Do I also refer to that as the sensitivity of the test, or is that separate?
Well, it is. You got to watch out. These companies, when they make these assays and they do this initial calculation of sensitivity and specificity, they're making sure that everything is done under just the exact right condition. Yeah. So they're going to make sure a C. diff toxin assay is going to say, we're going to collect that poop and we're going to test it within an hour. We're going to do everything just right. We're going to have people who that's all they do is they run this test for us. And so it's kind of, maximized when they do it. Yeah. Then you do have to look at it and say, okay, if the sensitivity of this test is supposed to be, I'll give you an example. Rapid antigen test for group A strep. It's kind of amazing. You look at those and you say, in the package inserts, they're all saying that they're 90%, 95, 98% sensitive. But then in the real world, they're like 50% sensitive, because they're making sure they get a good swab. They're not dealing with a little kid that's, screaming and feverish and unhappy. So they're making sure that everything is done exactly right to get those good numbers. So you do have to kind of look at that, take into account and say, this sensitivity that this company is telling me we should be able to achieve is based upon us doing everything just right. If we're going to have transportation problems, if we're going to have collection problems, that's going to reduce the sensitivity.
Okay, cool. Thank you.
You bet.
Thank you. Dr. Junkins, one final question. Since we have all of these home tests, rapid home tests out, and a question I frequently get is the expiration dates or shelf life on these. Do you have any comments on how can people still use these? Change, like what does it do?
Yeah, that's, okay. That's going to differ a lot. I will tell you, for us in a laboratory, we don't have much choice. Once something hits the expiration date, it's gone. These instruments that we use, they're smart enough to know that something's expired and they will refuse to run the test. It's kind of like, I don't know, something in your refrigerator, you buy a can of tomatoes or something that it has an expiration date on it. Your gallon of milk that has an expiration date on it. It's not like it magically goes bad once that expiration date hits. The test won't either. What it's basically saying is that the company that made it, they tested these things out for a certain amount of time and they still worked fine 6 months later. So we're going to put a 6-month expiration date on it. They may still work just fine if you go out 2 more months, 6 more months. You just have to realize that at that point, you're kind of walking, you're outside of the tested range here. It's going to probably reduce the sensitivity and specificity. You might end up getting a lot more of just invalid results, uninterpretable results. But exactly when that's going to happen is a good question, and unfortunately, I would say a rapid test, most of those rapid tests, you're getting me into, I don't know when it would go. I know they would probably work for quite a while after the expiration date. But if you have to realize if you get a negative test and it's 2 months past the expiration date, you can't really trust it.
All right. Thank you, Dr. Jenkins. I don't see, let's see. Oh, this was just a comment. When you buy a test in the pharmacies and grocery stores, there are now signs that say most of the expiration dates have been extended. Okay,
yeah, and that's one thing a company can do. They'll say, we've had companies done it too. They'll put a 6-month expiration date on it because it was rushed to market, and they only tested it for that amount of time. But as they keep a supply in their warehouse, they test them past the expiration date and show that this is still working. So, yeah, you might be able to get one of those.
Okay. Well, I don't see any more questions in the chat. Thank you all. Thank you, Dr. Junkins, for joining us again. And we will be back next week, Wednesday, 12 o'clock for Grand Rounds. This Grand Rounds is recorded and on YouTube. Our YouTube channel information is in the chat. We also have upcoming events in the Kentucky Infection Prevention Training Center. We have the Infection Prevention Bootcamp, October 4, 5, and 6. More information on our kyiptraining.org website, and you can register for that event. Next week, we have Stephen Fermanek, and he will be discussing propensity scores. If there's nothing else, thank you all very much for your time, and we'll see you next week. Thank you, Dr. Jenkins.
Welcome. Thank you.